Okay, welcome everyone. This is the RAPS Patient Safety Research and Development Salon, if you're on the wrong call, hosted by the Pittsburgh Regional Health Initiative. The salon is designed today to feature Pitt's patient safety research and highlight how UPMC is becoming a lab for patient safety research, discovery, and commercialization. Earlier salons also highlighted patient safety research at the University of Pittsburgh's Department of Biomedical Informatics, working with Carnegie Mellon University. So I'm so pleased to introduce our speakers who may not need much of an introduction given the people who are here now. Let me begin with Dr. Aman Mahajan, the Senior VP of Health Innovation at UPMC Enterprises. Congratulations on this role. And the Peter and Eva Safar, Professor and Chair of the Department of Anesthesiology and Perioperative Medicine. In addition to a very distinguished medical and academic career, Dr. Mahajan is also a successful entrepreneur, serving as founder and chief technology officer for 3 startups in the medtech field. He recently presented his patient safety machine learning model at a national AI and patient safety conference. Thank you so much, and we are very interested in hearing from you, Aman.
Thank you, Karen, and thanks everybody for giving me this opportunity to share our work. It's really exciting, as Karen mentioned. UPMC and Pitt certainly becoming a hub for innovation, and we are selectively but deliberately engaging, investing, and collaborating on projects with AI, different dimensions of AI. So I'm certainly happy to speak with those with all of you offline or after the meeting. One of the asks for me was sharing the role, which it's a new role that Leslie Davis and UPMC created, and the primary goal is to advance innovations, be those technologies, processes, healthcare delivery, new business models across the various divisions of UPMC, health services, the health plan, as well as those enterprises. So even the position is from the enterprises, but it's to translate all these new discoveries and innovations across all UPMC and Pitt. I do get involved in all the investments and the research that's with the goal to translate much of the excellence that we have into the commercialization realm. Today, I just wanted to, I know we have only a brief few minutes over here, so I'll share with, as requested, share the work that we've been doing with our partners across the entire UPMC ecosystem, our surgical departments, the nursing leadership, as well as our data sciences team. Much of the work's been done through the teams that we've built over the past few years, improving patient care, patient safety, and outcomes, and for patients undergoing surgery at UPMC. So let me just share, the presentation that you hopefully can see now. And this was a culmination of the work, which is now the clinical practice of that is ongoing. But the paper was published a few months back in JAMA Network journals. And it's really a model for predicting risk for patients undergoing surgery. And to provide an overarching concept over here, anesthesiology as a field has done a tremendous job in terms of improving patient safety through iterative changes in its practice, employing technology, being data-driven, creating in novel practice paradigms and evidence-based guidelines, to the point that intraoperative mortality is actually pretty rare. It's almost as best as U.S. industry best in class. People would equate to, for healthy patients undergoing surgery, the mortality rates similar to commercial aviation. So that's fairly rare now, and that's much to be proud of. Now, while that's great, when we look at the outcomes for overall surgery, especially outcomes after surgery, those actually haven't changed a whole lot over the past 2 or 3 decades. And in fact, if the mortality was after surgery was to be considered a category unto itself, it actually contributes. It would be constituting about as the third most common cause of death nationally, and the same rates apply worldwide as well. So some sobering facts, and certainly showing an opportunity for us to improve, health for patients undergoing surgery. And surgery, as all of you know, it's a big component of the health and healthcare that we provide for patients in our care. And from a financial standpoint, it drives the economics for U.S. health care system. And what we do know is that, and again, sharing some data points to provide further context, about 60 million surgeries being performed annually in the United States. So that's about more than 150,000 every day. And we know that patients that are high risk and have complexity, they actually have outcomes. In fact, 20% of these patients actually have modifiable risk factors. So the question then arises, can we actually quickly, rapidly, at scale, identify these patients at a time when some interventions can be made to improve the overall outcomes? And over the years, several groups, scientific societies, be that anesthesiology societies, the American College of Surgeons, American Heart Association, American College of Cardiology, each of those have actually, and small groups, academic groups, across the country and worldwide, have created their risk models to predict risk for patients undergoing surgery. And all of them have some limitation. They all have strengths, but they all have limitations, which hinder the ability to actually make impact at scale. And some of them require data from in hospitals, say after the patients have been admitted. By then, it's too late to make interventions to improving risk. Some of them are not scalable, or they're manually performed, especially the current reference or ubiquitously used model that's created by American College of Surgeons. They're fairly labor intensive and not automated, and not integrated easily into the clinical workflow, so that they can unburden the already busy and burnt out, surgeons, nurses, and the anesthesiologist. So they're not used very well, and some, of course, suffer from accuracy and reliability and robustness across system. So those were actually the gaps, or actually my overarching aims and goals to create a model that would actually make sure that addresses all those constraint points that exist. And we call it UPMC preoperative model, and we started building that when I first got here a few years back. And I'll share you with the process of how we built it. It's really we had at that point close to 1.5 million patients in our database. So it's 10x larger than anything that exists, and that provides some of the robustness that we see. It includes patients from under our care that come to our tertiary coordinated care hospitals, community hospitals, even rural hospitals. So fairly wide representation of the patient population, at least in the state of Pennsylvania. And it relies only on variables data that exists in the EMR. So we don't have to do anything additionally to acquire the information. We don't ask the patients to do anything else. We don't ask the clinicians to do anything more to actually to present this risk. It's a gradient boosted decision tree model, which allows us to manage all the large volume patients at its high dimensionality and an element of missingness that exists in all healthcare records over here. And about 3,000 variables, but mostly 300 domains that we've actually captured, and those include besides the patient demographics, their medical histories, importantly, it actually includes the social determinants of health, which now, our research and others recognizing that is a big contributor to overall, long-term risk and healthcare utilization. And we wanted to make sure that the model gets fully integrated into a clinical workflow, and the information that's is provided is at the fingertips of every clinician. It's available at the time the decision for surgery is made. The surgeon actually has that information to decide, how should the future care for this patient be rendered, and it allows better shared decision making. So the patient, as a consultant themselves, the surgeons and the medical teams all are on, have the right information and the same information, so they can actually engage in a better shared decision-making discussion about their care. So just a construct of how we actually created a training set and a validation set. The details not particularly important for this, but we actually create a very methodical, approach to building the model and testing its accuracy. With our large data sets, we ensured that the hospitals that were represented, there were about 20 hospitals that were represented in the training and the testing data set were similar, and the number of patients were equally distributed, also validating, helping validate the approach that we took. And as you can see, the model was tuned for various outcomes. Here I'm sharing mortality and MACE, which is major adverse cardiovascular and cerebrovascular events, big cost drivers and reasons for lack of patients returning to functional status after surgery. And the AURC on these were excellent for these models. We actually did one step further in terms of validation. Where we tested this model in a prospective manner where the clinicians were totally blinded. So we went on a silent mode for 6 months, where we actually acquired data and just predicted what would happen with the patient. And even in our prospective sort of future prediction model, we actually had a fairly high AURC. Just sharing with you what the NSQIP calculator looks like, which is American College of Surgeons one. This is what is referenced and used nationally as the gold standard, reference standard here. As you can see, you actually have to choose these drop-down menus, one by one to be able to create a risk. So you have to acquire that information from the patients first, and then actually be able to input that, and then it gives you, it's accurate. And has furthered the field so tremendously in terms of improving patient outcomes and quality. So they should get the credit they deserve in promoting the right approach for identifying risk. But it's not ubiquitously employed and is not at local levels. There might be some inaccuracy. So we actually compared our model with this, and we found that for our patients, our UPMC model that we created was actually better and more accurate than the NSQIP, American College of Surgeons model. And we went further. Rather than just leaving it as an academic exercise, we integrated this thing in our model into a clinical workflow. So you can see an application where any nurse, any surgeon, any physician, anybody who's taking care of that patient can look into any moment in time to saying a patient that's having surgery today or the next week, or a cohort of patients that are happening surgeries in the coming days and weeks, where do their risk profile lies and what might be contributing to their risk. And we, as a healthcare delivery system, we can actually now create pathways and create resource allocation, clinical teams, surveillance team, to say, let's focus more on the high-risk patients or higher risk patients as compared to the ones that are otherwise healthy. 70% of patients that actually come to surgery, they actually don't have major medical problems. So we need to actually focus and tailor our resources and clinical pathways protocols on the ones that are high risk. As you saw, and I shared the data before, those are the ones that are actually having the complications in there. So it allows us to have better shared decision making, better resource allocation, creating pathways and protocols that focus on those ones that are actually going to be needing the most intensive care. And we've structured, based on this in our paradigms, we've created the risk stratification, and we've created clinical pathways based on risk stratification. And then on top of that, we created digital health, protocols, which allow us to give both a standardized protocol driven, but yet personalized care to optimize outcomes for these patients. And these are now embedded within our EMRs. So if a patient has certain risk factors, they need, mental health, or they need nutrition support, they need diabetes management or hypertension or heart failure management. Once we've identified the risk, it allows us to automatically tailor and trigger these pathways so patients' outcomes can be improved. So care teams that are involved in this, and we implemented this approach across thousands of patients, 10,000 patients, and actually showed that it improved not just short-term mortality, but it improved mortality 2 years out. So we've been actually using these approaches for a few years, and as you can see, tremendous improvements that we've been able to achieve through this approach here. So just wanted to share with you an overview of how we went about creating this, why we did, and where we are in terms of our clinical practice. So thank you.
And certainly when we're looking at positive uses of AI ML related to patient safety, this is a wonderful example. As you know, at our conference, someone said, why do we need this quick? And anyway, that was an interesting conversation. So also thank you, Aman, and all anesthesiologists for what your specialty has contributed to safety around the world. Wherever we go, whatever country, the leaders in safety always seem to come from anesthesiology. So thank you for what started in the US and has spread. So now we did have a film crew here filming the work that Alex Sundermann and Lee Harrison and Art Dubrovsky has been involved in. Alex is here representing the team. He is an assistant professor of medicine and infectious disease at the Department of Medicine. Within the Center for Genomic Epidemiology and the Harrison Laboratory, Alex's research focuses on the detection and investigation of healthcare-associated outbreaks of infectious disease using genomic epidemiology. So now that you guys are captured in this upcoming documentary, we'd love to hear more about it.
No. At least I can't hear you.
No, we can't. Alex, there's comment while we wait for Alex to get his audio up.
Okay, I'm happy to. And thank you so much. Can you see my slides?
Yes, I can.
Okay. Let me, I'm having some challenges here. I got too many screens open. Let me just maximize this if I may. Okay, can you see my first slide, folks?
Yes.
Yes.
Yes, we can now.
Okay, great. Thank you. Well, again, thank you so much, Karen and Rob, for the introduction. What I want to talk about is an important problem in terms of how do we take care of really sick people outside the hospital. We consider our project an ICU without walls. This is funded by the Department of Defense, and I'm going to go into how it impacts patient safety by improving, hopefully, clinical outcomes for critically ill people in areas where there are limited resources, disaster response, mass casualty settings, large-scale combat operations like what we see in Ukraine, et cetera. This is a team effort, as you see here. I serve as the principal investigator in this DoD-funded effort called Trauma Care in a Rucksack, or TRACER. It involves folks from emergency medicine, critical care medicine, again, Artur Dabrowski from CMU with the OTAN lab. And I just want to highlight right now what we're seeing in Ukraine are the use of drones to evacuate soldiers with gunshot wounds, primarily to the arms and legs. They're all wearing tourniquets. They're all awake, somewhat alert, and they're putting them on drones and flying them up to 43 miles, putting 1 to 2 casualties on this. This was reported in The Economist on August 4th of this year. And I was in Warsaw a couple of weeks ago with them. I'm doing a big project with Ukraine, and they verified that they are using drones to evacuate casualties from the battlefield. U.S. military sees an important role for that, and they developed in January of 2021 a initial capability document that says we need to start looking at autonomous care and autonomous evacuation. So how do we resuscitate and stabilize someone with no human involved using AI machine learning? And how do we evacuate them without a human in the loop? To that end, our DoD funded work is looking at how do we rapidly treat and stabilize casualties from point of injury using autonomous technologies. We're also interested not only from a military perspective, large-scale combat operations, but as I mentioned, in resource-constrained environments in the civilian settings. We're leveraging unmanned evacuation to clear the battle space. What role does that play? Ukraine already doing it, I think, is going to drive the pace of development in the U.S. military and our civilian sector. It's important to note that on the battlefield, what we've learned from Iraq and Afghanistan, that 25% of the soldiers, sailors, and airmen who died, 88% of those deaths, 25% died in preventable death. And of those preventable deaths, 88% of those were from hemorrhagic shock, which is why Stop the Bleed program and other programs like that are so prevalent around the world. Military studies have shown that if you don't get to them and resuscitate within 2 to 3 hours, the chances of survival are grim. So given the challenges of care under fire, whether it's Ukraine, Afghanistan, or elsewhere in combat, and the challenges of administering personalized, that's the key word, personalized fluid resuscitation care in a pre-hospital civilian setting, there's need for a tool to automate these life-saving resuscitative measures. So the Trauma Care and RECSAC project, we're in year 5 of a 5-year funded effort. We have follow-on DoD funding that starts on 27 November for another 3 years to further develop this. We believe in the proverbial triple helix. You all know Watson and Crick's double helix. In my mind, the triple helix is industry, academia, and government all working together. Tracer truly reflects that. We have industry partners helping us come up with new biosignals of non-invasive sensors. You'll see on the right, on the left, we have DoD investigators that are part of our project, where we plan to not only use some of their research expertise, but also take this capability to the 59th Med Wing in San Antonio, Texas, where they're going to do the same kinds of experiments in a field setting. Where we value the relationship with UPMC and the pre-hospital data they provide us. I'll go a little deeper into that pre-hospital data, all coming from the STAT Medevac helicopters. Again, 23 choppers flying around 4 states. 19 are always flying, 4 are in the shop getting preventive maintenance, but those 19 choppers do about 13,000 medevacs a year. What we're doing is pulling out of that STAT Medevac database 18 to 50-year-old patients from point of injury to a level 1 trauma center, and using that data to inform us of how to build this algorithm. We used AI machine learning to clean the data. Again, if anyone that's ever been in the emergency room, the pulse ox falls off, you have vibration, you sneeze, or if you're an ICU doctor, the alarms and whistles are going off all the time in the ICU. So pulling out all of that bad data required machine learning just to clean the data. That allowed us to do, further machine learning. Our academic team, as you see, Pitt CMU, looking at 3 big areas of collaboration: knowledge building, physiological behavior, looking at these novel biosignals, and then automation, looking at closed loop control. So again, our hypotheses are there's in critical care medicine and emergency medicine, functional hemodynamic monitoring is alive and well. That means that I got someone really sick in front of me. I do something to them. I give them blood, I give them fluids, I give them drugs. I see what happens, and then I incrementally continue to stabilize them from a hemodynamic perspective. So we're using that functional hemodynamic monitoring and machine learning approaches to enable non-credentialed providers. That's important. ICU without walls, pre-hospital, to recognize cardiovascular instability. You don't know what you don't know. So how do I resuscitate just enough fluid to extend the golden hour? The concern is a lot of people that are unsophisticated in this kind of ICU care over-resuscitate. And over-resuscitation can be just as bad as under-resuscitating. So we go by, the International Fluid Academy guidelines and others to make sure that what we're developing again, extends the golden hour to 3, 4, 5, 8, 12 hours. And we use that across 3 different sources of training materials and validation. We have a large porcine animal lab. We've done over 50 pig studies already. We pull, as I mentioned, the Stat Medevac database. We have, I believe, the largest pre-hospital trauma data set. We have now 67,000 total patients, that's trauma and non-trauma. And this is both DoD and NIH funded work that we're doing. In the non-trauma, you see it's myocardial infarction, acute respiratory failure, sepsis, GI bleed. And of the 67,000, 22,000 roughly are trauma patients. So we take that trauma pre-hospital data on the back of a helicopter, which is voice talking back to base station, monitoring data from the Zoll monitor and other devices like a pulse oximeter. We have a little written mini record, and we have video data. We're intubating about 5 patients a month in the back of a helicopter. They have cardiopulmonary arrest, flying to Presby or some other level 1 facility. So all of that really rich data is all put together to do in silico validation of autonomous diagnosis and resuscitation. Then we test that in humans in something called the lower body negative pressure chamber, which is a validated model to do hemorrhage resuscitation research. This, again, Tracer provides a novel precision medicine approach to casualty care. How do I push, again, I'm pulmonary critical care trained, did 30 years in the Army, deployed to Iraq and Afghanistan, took care of a lot of sick people in combat scenarios. How do I push a skilled intensivist far forward when you don't even have a medic or an EMT? That's what the DoD is interested in. And the same sorts of situations could occur in the civilian sector. So we're using non-invasive sensors to enable ongoing recognition of these evidence-based biosignatures. Those signatures are put into algorithms to characterize the degree of compensatory mechanisms. We call that refit, or the resuscitation from shock using functional hemodynamic monitoring. Those biosignatures are then matched to an optimal treatment protocol based upon ground truth. What we're seeking is personalized, precise resuscitation. Again, if you've seen one critically ill patient with multiple problems, you've seen one critically ill patient. There are so much heterogeneity among people and how they respond that patient-specific, continuously optimized autonomous care, we think, will improve safety and outcomes. So we're looking at 3 different buckets in this algorithm: the compensatory autonomic vascular response. So if I have spinal cord injury or if I'm septic, my blood vessels don't constrict down like they should to increase the blood pressure to perfuse the brain, which is the ultimate goal. So we look at autonomic vascular response. Is the heart working properly and pumping blood? And then how about the tank? Is the tank full? What is the effective circulatory volume? These 3 things are being measured through a series of pulse pressure variation, stroke volume variation, to develop something called a dynamic arterial elastance. I don't want to get into the technicality of it, but suffice to say, our intelligence system that we've developed has 2 parts. FDA-approved devices that you see here, a Zoll monitor, a ventilator, and infusion pumps. These integrated medical device platforms, small form factor, enables the clinician locally or remotely to manage a patient. And then we overlay that with a computer tablet that has software as a medical device to do this physiological closed loop control. It's a system of system software application loaded on the tablet to allow local or remote management. So what we've delivered to the DoD over the last 5 years, we've done, again, 48 pig studies. These findings represent, and we've developed, again, an invasive algorithm using invasive monitoring, like a pulmonary artery catheter, an arterial line. And then we've taken that into Refit 2.0, which is non-invasive monitoring, which, again, on the battlefield in austere settings, you're not going to be able to do these kinds of invasive maneuvers. But our findings, we believe, represent the first time a complete personalized hemodynamic resuscitation protocol has been successfully implemented. We've also now done a series of pig experiments that I'll talk about, 4 pig experiments this past summer, where we take the pig, we traumatize it, we take it on the ground evac, we drive it out to the county airport for about 40 minutes, depending on traffic, throw it on a helicopter and fly it back, undergoing continuous resuscitation. And then what we've done with this pre-hospital data, This is, we believe, the most well-documented trauma and high-frequency data set available. This has garnered the support of DARPA. DARPA's funded us to take a look over a 4-year effort, all of our pre-hospital data going into a major program called the DARPA Triage Challenge. We provide the pre-hospital data. University of Maryland provides the inpatient data. But again, it just speaks to the value of this pre-hospital data that we've cleaned and used MI, machine learning, AI technologies on. Let me just segue in the last few minutes on what we're doing with this model. So we spent the first 3 years cleaning data, collecting data, developing an algorithm. Now we take a traumatized pig and put it on a helicopter and fly it after ground evac. This is pretty gruesome. I'm sorry it's lunchtime, but we've had 4 animal experiments. What you see here is this is IACUC and ACURO approved. So the Institutional Animal Care Use Committee, and that's PIT, and then the Animal Care Use Research Office, that's DOD, approved this study. We take this medieval device you see there, which we built ourselves, which is a validated device from other literature, and we develop an uncontrolled bleed. We open up the animal with a laparotomy, lacerate the liver, we have major arterial venous bleed. We lightly pack the animal, close the animal still bleeding internally, and the animal will die within 2 or 3 hours. Then we wait 30 minutes without intervention, and then we tell the computer, which you see in that bottom left, with Ted Lagatula, one of our nurse researchers, we tell the computer, okay, start resuscitating this pig. Give it blood, give it calcium, give it crystalloids, give it vasopressor support in the form of norepinephrine, manage the ventilator, total intravenous anesthesia is all being done. Again, we've done 4 pigs where we take them from the lab, take them to the top of Presby and fly them around Pittsburgh for an hour. We've done 2 pigs that way. Then we've taken 2 pigs, take them down the ground level where an ambulance is waiting and fly them out to the county airport. So we load animals 1 and 2 in the back of the aircraft with these FDA-approved devices. We have 2 safety officers on the plane in order to meet the Animal Care Use Committee needs and to sedate the animal in case the anesthesia is lightening up. But those safety officers, have never intervened on the pig in flight. So we take the last 2 animals, again, from Presby. You see here on Google Maps, we drive 28 minutes, 8.3 miles out to the county airport, 28 minutes on a good day. And then once we transport by ground, we load them on a STAT medevac chopper and fly them back. July 2023, we did our first of the 4 pigs in flight. We have, you see here, the infusion pumps with total intravenous anesthesia. We're using fentanyl and ketamine, again, pre-hospital device anesthetics you can use. We're giving blood, IV fluids, and pressors. And you can see the laptop with the physiological data monitoring in front of you. We also are interested in using much smaller form factors. This is a caretaker medical device. It's a non-invasive sensor that measures continuous pulse pressure waveforms. We interrogate the pulse pressure waveforms to come up with some of the signals that tells the algorithm how much blood to give, when to give blood, when to give fluids, et cetera. So we work closely with industry back to the triple helix. This is the actual first pig experiment. You can see the liver laceration from that device I showed you earlier. Now, we waited 30 minutes. The pig is lowering its blood pressure. Cardiac output is dropping. We resuscitate for 30 minutes. Then we pack the pig up. And anyone that's taking care of sick people and move them from the ICU to a CAT scan and move them from the ambulance to the OR, from the ER to the OR, it's an adventure, folks, trying to get somebody with tubes and lines and everything safely moved to a location. We pack up this pig. We make sure everything is still working. You see the blood hanging, the IV fluids, system go. We transport the pig on the stretcher for the ambulance with all of the equipment that you see here. Then we have a helicopter coming into the 12th floor Presby. Helicopter lands, everything's a go, equipment's functioning, transport the pig to the waiting helicopter, load the pig onto the helicopter. We have our 2 medical attendants, Lenny Weiss and Frank Guyette, just 2 superstar clinician scientists who I've had the pleasure of working with, riding in the chopper, making sure these 4 pig experiments worked well. They just kept an eye on the pig. They never intervened. Here's the pig with a endotracheal tube and the equipment on the helicopter. We fly around Pittsburgh. We then land 2 to 3 hours later, whether it's ground, air, evac, continuous resuscitation the whole way with no human intervention. Now we look at the post-flight 2.5 hours. At this point, mixed gas, the mixed venous saturations are decent, roughly 59%, mean arterial pressure of 68, cardiac output of 3.9. So the lactate level here on this venous gas is 1.8. So this is after almost 2.5 hours after insult. The pig is still pretty good, stable parameters. Here on the arterial blood gas on supplemental oxygen, lactate levels and all other parameters are looking good. With that, we were getting funding from the DoD to take tracer, which you just heard me present. And we've got a new project to expand its capabilities called cardiovascular resuscitation using informed closed loop system design. This is taking, again, that military grade ruggedized tablet, taking what we do at Pitt and now putting it into a DoD environment on humans and pigs. We're going to be looking again at that caretaker medical biosensor on the top left, using a mobile device for data entry application loaded on the miniature Android. That's the soldier with that on his wrist. We have the blood and pharma infusion pumps bottom left, and then the Thornhill medical device, which is a closed circuit ventilator monitoring and air exchange, which allows oxygen concentration from air, is our package. We start on 27 November with this new effort. And our targeted use cases are 3 that you see here. The initial intended use, care in the air. Again, large-scale combat operations, disaster response. I've got 10, 20, 30 really sick casualties. I got to load them on the back of a C-17. How can I manage them all? They're all ventilated. And how do I use this technology as a force multiplier? In addition, in the future, you do something called a joint precision airdrop. We have drones flying that drop this trauma care in the rucksack capability near the point of injury. We apply the technology. Then we take that casualty with the technology and resuscitation already started to a waiting unmanned helicopter for closed loop care during unmanned transport. I'll stop at that point. I know that was quick, but I just wanted to let you know that we're pushing the goofy meter on a lot of this technology for pre-hospital care with ICU without walls. I'll stop at this point.
So Ron, it's mind-boggling. And also, we won't have time to talk about it, but the civilian applications, whether it's civilian mass casualties or overflowing ERs, our ambulance services, I can think of many, but as I've told you many times, can you get tracer in an elevator? Because if I need a rapid response team, don't tell Paul Prampus, I think I want tracer. But anyway, thank you so much. It's just dazzling what is being put together here to care for injured warriors, and someday it'll come to us as civilians. So let me, just because we're so tight, Alex, what do you think about audio? Are you okay? You're there.
Yeah, perfect. Yeah, I switched to phone. Sorry about that. I've never had an issue with this laptop. But yeah, I'd be happy to take over again. And thank you, Ron, for coming in and filling in there for me for a second. But again, as I was saying before, excited to share some of this work that our lab is doing at the University of Pittsburgh with partnership of CMU to really change the paradigm about how we detect and intervene on outbreaks in hospitals because we're finding they're a bit more common. So the history of outbreak detection and where it currently stands right now, it's really been unchanged for decades. Since we think about John Snow in the 1850s of looking into cholera outbreaks, really what hospitals do is look for an increase of cases within a certain time frame. Often that's a nurse calling down on a Friday afternoon to say, we've had a few patients with C. diff infections. We might think that we have an outbreak going on. And what we found and other people have found is often that's very inaccurate at actually finding outbreaks. And whenever we do have those requests, we have to manually comb over the charts of these patients to see what's in common among these patients. Is it a certain provider? Is it a certain location? Are there procedures that they're going to? And what I may look at the patient record may be something completely separate that another individual is looking at the patient record. So you don't really get you get a lot of variability whenever you review them. One technology that is new is something called whole genome sequencing, which is essentially like a DNA fingerprinting that allows us to say two pathogens of patients' infections are essentially identical, meaning did they give it to one patient to the next, or do they get it from some type of common source? So it really connects the dots whenever we're trying to look into these investigations. But historically, this tool, which has only really been around for a few years, has been used after hospitals think that they have an outbreak. So it's retrospective in a sense, because they're trying to confirm or refute its presence. On the other hand, what we're doing, and I'll talk about in just a minute, and a couple of other hospitals, is using it prospectively to essentially show that we can detect many, many outbreaks that are otherwise just not picked up completely. And also, since we're modernizing a lot of our health record data, that health record data exists as a really good opportunity to try to automate this review that we're doing manually. And combining these together, we've created this cool tool called EDSAT, the Enhanced Detection System for Healthcare Associated Transmission, where it combines two different things. The first being whole genome sequencing surveillance, where we sequence every pathogen regardless of the presence or suspicion of an outbreak. And what this helps us do is detect the outbreak extremely early. So rather than waiting for 9, 10 plus patients to actually find an outbreak, we're detecting it on the second patient, because once we sequence 2 patient isolates, we know that we already have an outbreak. And the other thing that we're combining with this tool is an AI algorithm developed with our partners at CMU that's built based upon past outbreaks that we've had at our hospital, where we fed it the actual transmission routes. And what this algorithm does is scans the electronic health record, automates that review process, and really enhances that review process to help find transmission routes of these outbreaks that are detected by our surveillance for whole genome sequencing. And together we create the system called EDSAT, which ideally detects these outbreaks early, prevents future infections and deaths, but also saves hospitals costs as well. So how does it work in practice? Patients are in the hospital, and whenever the clinicians at the bedside suspect these patients have infections, they will order the specimen sent down to the clinical lab. Blood, sputum, wounds, anything, stool, sent down to our clinical lab to be cultured. Also, these patients have charge codes that exist in the EHR data. You get charges for medications, charges for procedures, your bed locations, and those exist as CPT codes. We also are able to de-identify and extract the provider names that are seeing these patients in the EHR as well. The only thing different that we're doing is we're taking those isolates from our clinical lab, bringing them up to our research lab and performing whole genome sequencing surveillance on the majority of those isolates that are cultured from our patients. We combine those charge codes with the sequencing data, so we essentially have a known outbreak where we have cases in the hospital and we have everybody else in the entire hospital that is not part of the outbreak. And what this AI algorithm does essentially looks at what is common among the charge codes, among our case patients, using our past examples of outbreaks where we know causes transmission, versus everybody else in the hospital and what they're exposed to through charge codes. And what it does is it identifies their outbreak, and it also provides a suspicion and a high probability routes that are probably causing this transmission in the outbreak that allows us to intervene and actually control that outbreak and stop it from spreading even further. So to test this hypothesis, we did 2 phases, one being a retrospective phase. So we took 2 years of clinical infections of major bacterial pathogens and sequenced all of those. But we did this retrospectively because we wanted to compare what our infection prevention department did during that 2 years time frame versus what EDSAT would have done with AI guiding it. What we found is that the traditional infection prevention methods miss outbreaks and misidentify outbreaks. So EDSAT, over the course of 2 years, identified about 100 outbreaks of almost 300 different patients. Many of these were very high impact outbreaks, one of them being an outbreak of interventional radiology with very unsterile contrast being injected to our patients. We also had another large outbreak of a contaminated gastroscope being used on multiple patients. And these outbreaks went undetected. Our infection prevention department did not detect them, but the AI algorithm with EdPAT was able to pick up all of these outbreaks. On the other hand, our IP department requested sequencing for what they thought were 13 different outbreaks of about 130 patients, and only 5 of them were part of an outbreak, and they were all detected by EdPAT. We also worked with some partners at Pitt Public Health to model the cost savings. And what we found is that if we were to have done this in real time, because the cost of sequencing is so low, but the cost of preventing one single infection is so high, our hospital could have saved nearly $700,000 over a 2-year period if it were using EdPAT in real time. So we took this really promising data and we said we need to run with this and we need to start it in real time. And that's exactly what we did. So we started this in November of 2021, doing EdPAT every single week, collecting these isolates and sequencing them. So we just hit our 2-year mark, and we're actually going to be writing up our analysis of what did we find in 2 years to share. But over the course of the 2 years, we found some really interesting outbreaks. We've had 9 endoscope-related outbreaks that were all detected at 2 patients. And this means that we detect this outbreak, we see that there's a scope in common among these 2 patients, and we simply remove the scope. When you compare that with our retrospective data, we had multiple endoscope outbreaks that were well beyond 2 patients. We also detected a pseudo outbreak within our autopsy suite where we had contaminated cultures that were being taken in our autopsy suite, clusters with patients that had the exact same ventilators used on them back to back that we're able to just remove and clean. We're also detecting clusters from outside facilities, other UPMC hospitals than UPMC Presbyterian, other nursing homes, where patients are sent to Presbyterian because they become septic, and we sequence those isolates, and we're able to detect outbreaks at other hospitals because of EdPAT running at UPMC Presby. We also detected this eye drop outbreak that was part of a national eye drop outbreak being investigated by the CDC of an extreme drug-resistant bacteria that caused multiple infections, lots of blindness, and even some deaths. And our program, EdPAT, detected it at months before the actual the outbreak was announced nationally. And once the CDC released additional details, we were able to link it to the CDC's outbreak. And in one of the patient records found that they had been using one of the eye drops implicated in the national eye outbreak. So this example, this last one, really shows that other hospitals were to use a program like EdPAT and share that data, we would really be able to expedite and detect these other national outbreaks much earlier than we're being detected right now. So next steps of what we're trying to do, right now in real time, we're doing the genomic surveillance. We're also at the same time trying to adopt our EHR AI algorithm in real time, where we can pull it every single week and analyze it as well. What we're going to be doing with this 2-year analysis is retrospectively apply our AI algorithm and see what did it find in comparison to what did we find in manual review. We're also looking to expand to additional pathogens as well and other UPMC hospitals other than Presbyterian, where we can retrain our AI algorithm to more community or rural hospitals rather than a tertiary hospital. But also we saw many examples where we detect outbreaks at other hospitals. So if we're able to expand to additional hospitals and communicate those findings, it'll be a exponentially gained system where we can really find and prevent these outbreaks from spreading from intra-hospital transmission. So it's not just me at the end that reviews these outbreaks. We have a whole team, Dr. Lee Harrison, who heads our lab, and Dr. Dabrowski for the Auton lab, who does the AI algorithm, and our infection prevention department as well, that carries out this applied system that we've created in real time each week to prevent these transmissions from spreading at UPMC. But I know we're a bit short on time, but the contact info is there, and if anyone has any questions, I'd be happy to follow up.
Thank you so much, Alex. As you know, I'm very excited about this. We've been following data on HAIs for now about 27 years, and I do think we need some fresh thinking to have the kind of breakthroughs that we need desperately. But also the interesting issue we have here is that you really have reached out, multidisciplinary approach fresh thinking, and hopefully we'll bring more of that to containing HAI. So I can't thank you enough, everyone. We are doing we've commissioned a documentary about exciting breakthroughs, and Alex's team passed, so the documentarians came out. So Evan Facher, you are the perfect person to follow up on all the excitement we've heard. So let's talk a little bit about the commercialization process and opportunities at Pitt and UPMC. As Vice Chancellor for Innovation and Entrepreneurship, you're the right person to do it. So please tell me if my thinking is wrong. So my thinking now is, first of all, you can hear from the presentations today, we're beginning to use the technology that's available, which is really important to vastly improve patient safety. So I wonder what will get health systems to adopt, to pay for and adopt and spread breakthroughs, even if we make these discoveries, because right now finances are tight. So in my mind, and you can tell me if I'm wrong, if we can get these kind of breakthroughs and there's a commercialization opportunity, health systems will not only want to develop these breakthroughs, but they will want to deploy them widely in their own system to begin with. So help me understand how are we going to not only commercialize, but spread and sustain these improvements?
Sure. So I'll just take a couple of seconds. I'm not going to use slides given the time we have left, but I'll just walk you through at a high level how this occurs at the University of Pittsburgh. So at the University of Pittsburgh, the office that I oversee is called the Office of Innovation and Entrepreneurship, and it's really composed of 5 separate units that are all focused on how do we grow the economy around southwestern PA and the Commonwealth, and a good portion of that is based on innovations, whether they came from faculty, staff, students, or businesses in the region. The university has a role in trying to help grow those innovations, help scale them so that there can be impact, not just from an economic perspective, but also from a societal benefit perspective. So inside of Pitt, the technologies that are created with the $1 billion plus of federal funding that we get all flow through what we call the Innovation Institute. So the Innovation Institute oversees the university's IP portfolio, the management of that, the licensing of technologies to for-profit companies, the creation of new ventures based on those technologies, as well as the education for faculty and staff on how do you move an idea to the commercial realm, and so that you can partner it with an existing company, or you can create a new company based on it. So on an average year, we create between 13 and 20 new startup companies based on university technologies, and we do about 150 transactions with third parties, giving them access to university intellectual property. So one of the ways that these things find their way out the door is purely through that technology transfer, that working that we do with existing companies, and a lot of the work that we do in creating new startups that can form and stay in the region, and they can certainly go elsewhere, or large companies, which in our region typically means that they're going elsewhere. The other organization that plays a role in this is called the Office of Industry and Economic Partnerships, which is within my office as well. This group is focused on the professionalizing the way the university handles business development and alliance management with large corporate partners, as well as with the venture capital community. So we have a team of about 8 people that are purely focused on working with investigators on campus to understand how do those technologies get sponsored research from these third parties, and how do we, in a more strategic fashion, work with existing companies to give them access to the technologies that we are creating on campus. And the third piece that I'll talk about is an organization that we created about 5 years ago called LifeX, and that was really under the realization that from an economic development perspective, once technologies left campus, if they were going to be formed into new ventures, the ecosystem really hasn't existed around southwestern Pennsylvania to take health science-based companies, life science-based companies, to grow them and scale them so that they can bring their intended societal benefit locally. So LifeX is an entity that is focused on working with early stage companies. Does everything from education to acceleration, to direct investment. We have about a $16 million, $17 million venture fund where we can do direct investment into startup companies so that they can take these technologies created in our labs or Carnegie Mellon's labs or Duquesne's lab or from any other region, bring them to the region so they can grow and scale here and provide their economic benefit as well as their kind of societal benefit. So with that, I'll end kind of a little bit of the explanation of how at Pitt specifically we're involved with taking a lot of the technologies that you just heard about and bringing them to the marketplace.
And let me ask you the big question, then how in tight financial times, how do we get our big health systems to buy these discoveries?
Well, I think, at least in our experience, the good ideas always float to the top. We can always find money for good investments in bad financial times, good partners in bad financial times. It really hasn't hindered our ability to get technologies to third parties, to healthcare systems, to large pharma, to large physical sciences companies. Well curated technologies that have a real societal benefit will find money to develop them and be deployed.
Well, I thank everyone involved today. What we are going to do, we do have Neal on video. He couldn't be here, so we videoed his.
Good afternoon, and I'd like to thank Karen for the invitation to present today. I'm sorry that I couldn't be with you in person, but delighted to take a few minutes to speak to you about our emergency general surgery verification program as a large quality initiative at UPMC Presbyterian. I'm the director of emergency general surgery for UPMC and serve as a vice chair of surgery in the Department of Surgery. In my clinical practice, I'm an acute care surgeon. And so what that means is I wear a number of hats. Some of you may be familiar with our systems in trauma care as well as ICU care, and certainly in elective surgical care. But what I'm going to be speaking to you today about is the concept of emergency general surgery. So when you think emergency general surgery, think presentation to the emergency room, the hospital ward, or the intensive care unit with things like bowel blockages, appendicitis, gallbladder infections, colon perforations, and ulcer disease. And as it turns out, the outcomes in emergency general surgery are exceptionally poor. Emergency general surgery represents only about 11% of all surgical admissions, but cumulatively, that is greater than 50% of the mortality in an inpatient setting in the United States. Now think about that for a second. A small percentage of admissions driving 50% of the mortality. Emergency general surgery represents over 500,000 procedures annually, but really it boils down to just 7 procedures, 7 very common procedures that account for most admissions, death, complications, and costs on an inpatient setting. And so this is a very common clinical presentation, but has really never been the focus of a major quality initiative until now. Emergency general surgery is a huge part of what we do at UPMC Presbyterian. As you can see here, we saw over 2,000 patients in a single year in 2022, with more than 1,600 operations, many of these being in patients over the age of 65, and a high percentage even over the age of 80. And so we have developed a solution to this problem of poor outcomes in emergency general surgery, which is leadership in a nationwide verification program sponsored by the American College of Surgeons and the American Association for the Surgery of Trauma. The focus of this program is to deliver the same kind of quality that we have emphasized for elective surgery in cardiac surgery, transplantation, and other areas for this very vulnerable patient population in emergency general surgery. This is quality for patients across the spectrum of need that will be driven by standardized protocols and organization of our hospital system around timely, effective care and teams built in structure to address the specific needs of emergency general surgery. We also, for the very first time, will be able to capture data specifically about this patient population through an emergency general surgery focused element within the National Surgical Quality Improvement Program. We have built a large committee, which consists of representation from numerous disciplines throughout the hospital, representing administration, nursing, physician leadership in multiple different consulting areas, really to address the breadth and diversity of care that is required for our emergency general surgery patients. We are already winning at UPMC Presbyterian in this structure. We are building on more than 30 years of infrastructure in trauma care, which has resulted in one of the nation's leading accredited trauma centers, to create excellence in clinical care within our acute care surgery model to focus on this patient population in emergency general surgery. We have already launched pathways of excellence to design protocols to specifically address those common conditions that I showed you that have long been driving morbidity and mortality in a hospital setting, but have really been under-recognized and have not been the focus of an initiative like this. This is also part of a system-wide effort for UPMC in surgical services across hospitals, not just UPMC Presbyterian, to assure that we are delivering care to the right patients in the right hospital. And we've built a unique data-driven approach utilizing the strength and the backbone of UPMC clinical analytics to hone in specifically on our emergency general surgery patients and have a level of granularity in data that was previously unprecedented. These are some of the many proposed emergency general surgery quality topics, which include figuring out the right way to get patients from outlying facilities to the correct hospital to render care. A specific focus on our older patients, our geriatric patients, which are amongst the most vulnerable and have the highest morbidity and mortality. We have a number of other protocols that are listed here on this slide that are low-hanging opportunities for quality that have never been addressed, but stand to revolutionize the inpatient surgical care that we provide to this patient population. We are also leading the charge in this initiative through research and innovation in emergency general surgery. What's demonstrated on this slide is just one example of our leadership in that research space, where we have identified in a recent publication that disadvantaged communities lack access to emergency general surgery. You see the heat map of the country here, and what we want to see is blue. These are areas that have a high access to care, but have low areas of deprivation. And unfortunately, what you see is that a majority of our country is in the red, right? Indicating that there are potential disparities in access to emergency general surgery care, particularly for vulnerable patient populations. This geospatial access model is a novel and innovative approach to understanding how we regionalize emergency general surgery care in a way that's never been done before. We are striving to improve quality and derive indices for care that will improve patient safety. This will, for the first time, standardize data collection and reporting for emergency general surgery and be part of a process system-wide at UPMC for assuring that we assign the right patient to the right hospital for emergency general surgery care and triage. Our participation in this will allow us to be the first in the nation and certainly in the region to achieve this verification, demonstrating our leadership and creating a safety net for general surgery in our region. Our strategic goals include engineering the ultimate patient experience within UPMC, focusing on people first, but through a protocolized and organized team vision for these common conditions. This will give us the opportunity, and we will settle for nothing less than the highest quality metrics and delivering high value care while we lead in innovation and transformation in a space that is wide open with opportunity to do this. This will improve the care for our most vulnerable patients in this population, and I really think stand to be revolutionary for inpatient surgical care. I'm tremendously blessed to lead this incredible and diverse team, and very excited to bring you this brief introduction of how we are going to change quality for emergency general surgery. Thank you for the opportunity to speak.
So with that, I can't thank everyone enough. Is there anyone else that, and I know some people are going to have to run, anyone have a question? Evan, you and Alex are still here. We might have lost Ron and Aman. Ron's there. Okay. Does anyone have a question? Ron, Evan, Alex.
No question from me, Karen, but a further comment. That whole project I presented, we're now in discussions with DARPA to, instead of putting the pig on a helicopter, we're going to put it on an unmanned drone and fly the animal around Pittsburgh in areas where a drone can fly. So at any rate, we continue to pursue autonomous care in all its glory. So thank you for this opportunity to speak.
Well, it's dazzling. I love it. And we all are hoping that many of these discoveries get to the civilian population sooner rather than later. But all this excitement going on here in Pittsburgh for Evan, hopefully there's a lot to commercialize. And it's exciting to be here at the very beginning, at the ground level. So thank you all. I don't think anyone's going to have chopped liver or ham for lunch, but it was a great presentation, Ron.
Thanks. Appreciate it. Thank you all.